All right. Excellent. There we go. Okay, so the general outline here is, as I mentioned in the blurb, we'll be looking at different types of arthritis, not necessarily in depth, but it is nice to and interesting to have a look at the different types of arthritis, because there are so many, and actually have a look at where sort of they and how they originated, perhaps the causes behind them. The next sort of topic we'll be looking at is common comorbidities, and just discussing those in relation to arthritis and how they may affect us long term, and then some common adverse effects of medications that you may be on. So this might be more relevant to people who have autoimmune, autoinflammatory type arthritis conditions, but also very much will be relevant to those with osteoarthritis also. Okay, so you will have seen this slide before. So very briefly, and we all know that there are many different types of arthritis. You generally have, most common types of arthritis are osteoarthritis, rheumatoid arthritis, and gout. We're going to have a look at sort of the differences between those in a moment. And then on the other end of the spectrum, in terms of how common things are, we have the least or the less common types being juvenile idiopathic arthritis, psoriatic arthritis, and ankylosing spondylitis. And we might like to have a look at the differences between these types of arthritis, and I've sort of categorized them into inflammatory forms and non-inflammatory forms. And so essentially this slide is just to point out the differences between them, and including other musculoskeletal conditions as well. So we have inflammatory conditions, and these are our rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, reactive arthritis, lupus, polymyalgia rheumatica, and gout, pseudo-gout. These are all have some form of autoimmune or autoinflammatory component, and they often have a multifactorial genesis. In terms of non-inflammatory, we have osteoarthritis, tendinopathies, which may or may not, often may not, relate directly to osteoarthritis. We have fibromyalgia, which is more a nervous system or neurological condition. Nerve entrapments to do with, for example, sciatica, carpal tunnel syndrome. And we have non-specific, we have back pain, which includes non-specific low back pain. So I guess in terms of inflammatory, non-inflammatory, and their genesis or their cause, this is where they lie in these two sort of categories. And what I'd like to talk about next is in terms of autoimmune conditions, they often, or most rheumatic and musculoskeletal diseases can be placed along a sort of spectrum of disorders, with autoinflammatory diseases and autoimmune diseases representing the two ends of the spectrum. And this is a really interesting concept, or interesting to note that there is a difference between autoinflammatory and autoimmune. And I'm wondering if anybody sort of was aware that there is a difference between them, and that the arthritis conditions that are inflammatory actually sit on either one of these spectrums. And so if you weren't aware, we have the autoinflammatory side or spectrum or cause of types of inflammatory arthritis. The autoinflammatory rheumatic or musculoskeletal diseases, this is based on the innate immune system. And it's what we call the body's first line defense against germs entering the body and or injuries, soft tissue injuries. So the autoinflammatory or innate immune system responds the same way to all germs and foreign substances and tissue damage, which is why it's sometimes referred to as the non-specific immune system. It acts very quickly. For instance, if we were talking about bacteria entering the skin through a cut, for example, this would be detected and destroyed on the spot within a matter of hours. The innate immune system has only limited power to stop germs spreading, which is why we have the autoimmune system as sort of that larger, big powerhouse backup system. So the innate immune system consists of protection offered by the skin and mucous membranes and protection offered by the immune system cells, or these defense cells and proteins. So we have cytokines, which are proteins, and larger white blood cells, which are just general defense cells. So as you can see on the screen here on the slide, we have that sort of red side end of the spectrum being autoinflammatory. Now, I'm certainly not going through all of these, and some of them I'm not even really too sure what they are in depth, but you can see how a form of arthritis, gout, which is one of the most common forms, sits on that autoinflammatory side of things. It's not necessarily an issue with the actual immune system. It's more so that it's that first line innate inflammatory system setting in due to the buildup of uric crystals. We have spondyloarthritis or arthropathies in here. So we have the innate immune system sitting in here. We have some forms of juvenile idiopathic arthritis as well, both oligo and systemic. So, and we also have adult onset of Still's disease. This is all based on that innate immune system conditions. Also very interesting, these is non-sex dominant. So, which I found interesting because I felt more males tended to have and develop gout than females. But anyway, interesting point to look at. This is just based on a study, by the way. So may not also be 100% accurate and just based on the cohort or participants they had. So on the other side of the spectrum here, we have what's called the adaptive immunity or adaptive immune system. And this is what we call the autoimmune system. So this is adaptive. It takes over from the innate immune system and helps if the innate immune system isn't able to destroy germs. So the difference between the two here is that the adaptive immune system can specifically target different types of germs that cause infection. And the other difference is it doesn't act immediately and it's not very quick acting. It takes a long time to respond. And this is where we get and we build immunity to some forms of conditions by the means of developing and creating target killer cells, T lymphocytes and B lymphocytes, and other antibodies in the blood and other bodily fluids. And so what's really interesting to note is that rheumatoid arthritis seems to sit more on this, more on the spectrum of the adaptive immune system being the main driver and cause of this condition, the same as systemic sclerosis and polyarticular, juvenile idiopathic arthritis, and Sjogren's. In saying that, the middle section here can seem to be in sort of a mixed state. So it can be both caused by innate, but also adaptive. And so I thought that was a very interesting point to make and to bring that up. And I guess the reason being is that the better that we understand the pathogenic pathways of autoinflammation and autoinflammatory conditions in rheumatic and musculoskeletal conditions, it helps design targeted treatment strategies. So for example, you've got non-steroidal anti-inflammatories. Say we're looking at somebody with rheumatoid arthritis. This is the reason why people with rheumatoid arthritis may take non-steroidal anti-inflammatories like an ibuprofen, because this helps reduce and dampen the innate inflammatory process. Okay, but then you'll have systemic corticosteroid therapy You'll also have DMARDs and biologics, which then dampen or target to dampen the adaptive autoimmune system. So it's very interesting to note that the different drugs that we have actually target the different types of immune systems we have, which is why it's really important to ensure that we take our medications as prescribed at the time that we've been told to do so. So I thought very interesting to share with you if you didn't know that already. In terms of the features and looking at the differences in terms of inflammatory and non-inflammatory conditions, and you obviously dealing with a form of arthritis may already be very well aware. The inflammatory features, obviously, these are categorized as just mentioned by an autoimmune and or an autoinflammatory or both type of condition. The onset, because of that, that nature that it's autoimmune based, is that it's fairly sudden onset, often relapsing and or remitting. Often, but not all the time, arthritis conditions that are inflammatory are often attacking joints symmetrically, but not always. Just depends on the condition. Often attacks smaller joints. Symptoms are often better with activity, obviously not if you're in acute flare-up stage. And there are increased inflammatory type markers, much more than non-inflammatory types of arthritis like OA. There can be multi-systemic features. So in terms of, for example, a rheumatoid arthritis can affect other organs in the body as well. Psoriatic arthritis can affect skin and nails, for example. We have morning stiffness, often lasts more than an hour and worse after prolonged rest. And in terms of inflammatory features, there's often bony deformities. Compared with the non-inflammatory features, this often is degenerative. It's sort of an insidious onset. And again, it's very multifactorial in terms of the reasons and the causes behind the development of arthritis, or in this case, osteoarthritis. Often, osteoarthritis affects the body in an asymmetrical pattern. So often it's just the one left knee or the one right hip. Not saying that that's a blanket statement, but certainly I'm just generalizing here. They're often weight-bearing joints as compared to the inflammatory features, and distal interphalangeal joints. So the very tips of the fingers here, for example. Symptoms are worse on initial movement and activity. They are eased with rest, which is why sometimes it can be quite difficult to exercise, knowing full well that it's going to hurt while you're initiating, but it's also probably going to be better when you rest, so you just want to stay rested. Symptoms often are worse later in the day. We often can hear and or feel crepitus, so that's that sort of crunching or popping sound. Morning stiffness less than 30 minutes. And while we still can get bony deformities with an osteoarthritis, we can certainly also get bony enlargements as well. So often we get osteophytes that grow outwards from the joint itself, and therefore creating enlarged joints. And so I often say, like, which is worse, so inflammatory or non-inflammatory? Well, that's probably not for me to say, but in saying that rheumatoid arthritis or those inflammatory type forms of arthritis, the progression of those is probably more challenging to predict. And you're often on, and you can be on some pretty hectic medications to dampen the immune system, which leaves you susceptible to other infections, viruses, and bacteria. So in that sense, the perhaps the inflammatory features from that point of view may be worse than osteoarthritis on its own. In saying that, osteoarthritis can also result in severe disability. Okay, I thought this was very interesting as well. So sort of comparing the different types of arthritis and the joints that they attack. Now, remember, this isn't the rule to these particular conditions. There's certainly exceptions here, that's for sure. And obviously, this picture here doesn't include all different types of arthritis. So for example, there's no ankylosing spondylitis in here, for example, just an example. But generally speaking, osteoarthritis, as you can see here, can affect in that asymmetrical characteristic, one knee, for example, or one hip, for example, and they're often weight-bearing joints. Osteoarthritis often spares the wrist joints and the metacarpal phalangeal joints. So these ones here, most often affecting the dip and the pip, so the distal and the proximal interphalangeal joints. So often. Now, that's not always the case. I know my mum, she has osteoarthritis, and often it actually bothers her most in her wrist. So again, not a rule. There are certainly differences between the two. We have rheumatoid arthritis. Now, rheumatoid arthritis often affects, remember, those smaller joints, very similar to the psoriatic arthritis here. However, rheumatoid arthritis is often symmetrical in its presentation. So both knees, for example, both shoulders, both feet, for example. Rheumatoid arthritis more often than not affects the wrists, the little carpal joints in here, the carpometacarpal phalangeal joints, so these ones all here, and the proximal interphalangeal joint. So after your first knuckle here, it's the middle joint. It'll often spare the most distal joints, interestingly. Psoriatic arthritis here. I'm sorry, and before I move on, rheumatoid arthritis obviously not only affects the joints and the tissues that are surrounding that joint, so extra articular tissues, it can also affect organs as well. So you're looking at heart, eyes, for example. Psoriatic arthritis, asymmetrical in terms of its presentation more often than not. So it either affects many joints, more than 4, which is the polyarthritis, or oligoarthritis is 4 or less joints. While rheumatoid arthritis can involve spinal involvement, like for example in the neck, we often don't see it more so in the spine. We see it more in the smaller joints. Psoriatic arthritis can affect the thoracic lumbar regions of the spine. And again, affect weight-bearing joints like the knee, and also the dip and pip joints of the fingers as well. Then we have gout and pseudo-gout. So a different form of arthritis altogether, based on a very acute inflammatory process due to the build-up of uric crystals, which often float down because of gravity and affect the big toe, essentially. But it can affect other joints as well. Often the big toe, and it's often asymmetrical. So it comes on very, very suddenly, very painful, lots of swelling, very red, all those sort of cardinal signs of inflammation. It can last for a couple of days or weeks. Pseudo-gout presents exactly the same way, but instead of the buildup of uric crystals, it's more calcium deposits or calcium crystals. And this affects, again, the characteristics here are often asymmetrical, affecting only 1 or 2 joints, and these are often the knees and the wrist joints. So again, very interesting comparison there. And again, generalizing. If I would ask you if you had psoriatic or osteoarthritis, some of you would go, yes, that presents the same as me, and then some of you might go, actually, no, I get it in XYZ, and I have this, and it doesn't match up with the pictures on the screen. But they're just interesting points to note. So when it comes to comorbidities, let's start off by seeing if you would like to share what you have. So I have a couple of polls that I'd like to ask, and these are the people specifically with I guess, let's say primary or initial osteoarthritis. So if you've got osteoarthritis, could you please respond to this particular poll that I'm going to put out? Now, this is anonymous. We don't see who says what, we just see the amount, the end result in terms of how many people selected what and not who, okay? So if you've got osteoarthritis, I'm going to put up a poll here that includes the most common comorbidities for those people with osteoarthritis. So I'm going to launch that now, and you will see that pop up on your screen. If you could participate, that would be wonderful. Unless I've got no one in here that with osteoarthritis. Okay, there we go. We've got a few people coming in now. Will also depend out of the 26 people who have osteoarthritis, of course. So we've got 10 people already. I'll give it another 30 seconds. Very interesting. Now, once again, the poll answers here, or questions and answers, they're anonymous. However, I'm just asking, you certainly don't have to participate. Where it says other, and you may have selected other, if you would like to share what you have, you can please use the chat box for that. But in saying that, we will obviously see your name. So if you wanted to keep what other comorbidities you have anonymous, then don't. But if you would like to add them into the chat box, you can, as that would be interesting. Okay, I'm going to end the poll. I'm going to share these answers with you because you may like to know what other people in this group are also dealing with. So can you see that now? So out of the 15 people that responded of this group of 26, so these 15 people have primary osteoarthritis. For us, 27% of those 15 people have a form of heart disease, including cardiovascular disease. 40% of these people have obesity, doctor diagnosed, and or are overweight. 60% have a mental health condition. So for example, depression or anxiety. No one has diabetes, which is interesting, which is great. Good to see, but also very interesting. And some people then selected other. So I'm going to have a little look here in the chat. Yeah, good points. Actually, I'm going to come back to some of those questions in a moment. Somebody has mentioned they may have AS. Someone may mention there's no way to indicate osteopenia and pre-diabetic, as in my case. Yep, fair enough. Yep, good. Okay, excellent. I'm going to address some of those comments in the chat box now. Excellent. Thank you for participating, everybody. That was really interesting. So obviously, I haven't been able to, I wasn't able to put all the comorbidities within that box. What I did is chose the most common comorbidities. As I was doing my research, these were the ones that popped up the most for those people with osteoarthritis. So obviously there is an increased comorbidity and mortality rate for those people with osteoarthritis. Over half have one other chronic condition, as we saw. And a third of people with osteoarthritis actually have 5 or more chronic conditions, whether or not directly due to or related to osteoarthritis. There are other chronic conditions as well. But we also need to remember that osteoarthritis is a condition that we develop as we age. So as we age, the risk or the prevalence of developing other conditions as we age also increases. But at least 1/3 of people with osteoarthritis have heart disease. which is a very broad stroke of all conditions of the heart, essentially. And then often people will present with metabolic syndrome, which includes obesity, diabetes, including pre-diabetics as well, of course, and cardiovascular disease. So diseases of the heart that are just relating to the vessels, essentially. So 57% of people with knee osteoarthritis present having obesity or overweight. More than 1/3 of people with hip and knee OA have diabetes, and people with hip and knee OA have twice the rate of cardiovascular disease. 1/3 of people over the age of 45 with osteoarthritis also suffer from depression and anxiety. So these are really interesting points, and I was interested to see the results of that poll, in that perhaps 1 or 2 may have been pre-diabetic, but no one actually had diabetes. So that was interesting. Good, fantastic, good to hear, but interesting not to see that. But certainly reflective of people maybe overweight, obese, or have some form of heart disease or cardiovascular disease. Also, people mentioned suffering from a mental health condition, clinical or not, depression and or anxiety. And so we can actually have a discussion here as to why this might be the case for some of these comorbidities. But right now I might just pump the brakes on that, because I'm going to talk about that just in a moment. So these are the 3 main comorbidities. And don't worry, I haven't forgotten osteopenia or osteoporosis when it comes to osteoarthritis. I'll speak on that in just a little bit. So these are the 3 comorbidities. This was taken from a study. Yeah, it was over 10 years ago, though I'm sure maybe the percentages may have changed, but the 3 main comorbidities for those with osteoarthritis, they have still remained the same to date. So people with arthritis often have other medical conditions as well, as we've spoken about. And some of these conditions can worsen pain and worsen the condition. And sometimes they're just a vicious cycle. Others find it hard to obviously manage the disease, or these conditions can make it harder to manage the symptoms of your arthritis. So what we have here, the relationship between OA and comorbidity. So firstly, as I mentioned before, advancing age. So aging related changes in joints, in the matrix, and this at the matrix and cellular level of the joint itself, like the cartilage and the periosteum, so the tissues that surround the joint itself, the bone itself. So these create conditions conducive to develop osteoarthritis. While having severe osteoarthritis, debilitating and very painful, shouldn't be common as we age, but certainly changes within the cartilage and joint health do change as we age. That is fairly normal, just like wrinkles, just like gray hair. That's all fairly normal. But chronic low-grade inflammatory processes called inflammaging occur in all aging tissues and may contribute to the development of OA and help explain the connection of osteoarthritis and other chronic diseases such as heart disease, because we know there is often low-grade systemic inflammation present in those people who have a form of heart disease. When it comes to reduced physical activity, so physical inactivity is a known risk factor for most of these presenting conditions here, these chronic conditions: obesity, diabetes, and heart disease. And these in themselves are risk factors for many other chronic conditions. So they're often just chasing their tails. You know, so if you're overweight, then you're potentially less likely to exercise. That may increase your risk of developing heart disease and diabetes, but it also may help increase the risk of developing osteoarthritis. But you may have had osteoarthritis because you had, for example, heart disease because of the low-grade systemic inflammation, which therefore you're not as physically active, and therefore you're more likely to increase or gain weight, for example. So it's just this constant vicious cycle and interrelated relationship of these chronic illnesses. So what's really interesting about obesity, there's a strong risk factor for comorbidities like cardiovascular disease, hypertension, diabetes, is regarded as the strongest modifiable risk factor to the development of osteoarthritis, particularly of the knee. Moreover, it has been associated with high risks of disability, which impacts ability to exercise, and which is the first line intervention of osteoarthritis and other chronic conditions like hypertension and diabetes. So the connection between obesity and OA is both mechanical and metabolic, and I've spoken about this before. So in terms of mechanical impact of obesity on OA, excess body weight puts extra stress on weight-bearing joints. Men and women who are obese have a 2.8 to 4.4-fold increase in developing osteoarthritis, particularly of the knee. For each kilogram of excess weight, the risk of developing OA increases approximately by 5 to 10%, which is fairly significant. Obesity can also change gait mechanics, so how we walk, and this may affect the distribution of weight across bilateral joints, resulting in damage in articular cartilage and other tissues. In terms of its metabolic impact, this is interesting. Excess body weight is also associated with increased risk of osteoarthritis of the hand, suggesting that metabolic changes related to obesity, so not just excessive weight-bearing activities, contribute to the development of OA. So metabolic syndrome, which is characterized by insulin resistance, hypertension, issues with fatty lipids, and visceral obesity, it's more prevalent in those with osteoarthritis than without. So that's also really, really interesting. In fact, metabolic pathological changes that occur in a joint with OA have been directly linked to insulin resistance, low bone density, and alterations in collagen production, and the impact of LDLs, which is a low density lipoproteins, that form bones essentially, or affect the bone formation and develop low-grade systemic synovial inflammation. So there are many knock-on effects of having not just one of these, but nearly one or two or three of these conditions. Then we have diabetes. Long-standing type 2 diabetes is a predictor of severe osteoarthritis, knee and hip predominantly. Also, this is independent of age and body mass index. Again, very interesting. And then we have hypertension and cardiovascular disease or heart disease. So research has demonstrated a relationship between radiographic and symptomatic knee OA and the development of hypertension. So people with knee OA have a higher chance of developing hypertension than those without it. So as you can see here, there, the graph shows the differences between those people who have arthritis, they're the blue line, and then people without arthritis, and they're the black line there. So you can see, without a doubt, people with arthritis, there are more of those people with obesity, diabetes, or heart disease than those people who don't have arthritis. Okay, so now we're having a look at comorbidities and those conditions and having a form of inflammatory arthritis. So this is anywhere from rheumatoid arthritis to your psoriatic ankylosing to gout, for example. So I'm going to throw up another poll. So those people who have a primary inflammatory arthritis, if you would like to participate, that would be great. So for you guys, let's have a look at the comorbidities that you may have if you would like to participate. I'm launching that poll now. And let's see what we're looking at. All right, here they're coming through now. Thank you for participating. So before we had about 15 or 16 people out of the 24 with osteoarthritis. So I got 15 people again participating in this one. I'll give it just another 20 seconds. Again, very interesting. All right, that's a minute. I'll end the poll. Thank you for participating. Again, if you wanted to share your other comorbidity condition and don't mind having your name put to that, you can certainly share that in the chat box. I'll end the poll and I will share with you the results. Remember, these are anonymous. So you should be able to see those results on your screen now. So 38% of the 16 people here today have a form of heart disease or hypertension, 63% showing with depression, 56% comorbid with osteoarthritis, 6% with kidney or liver disease, 19% with osteoporosis, 6% lung disease, and 44% other. Okay. Oh, wow. Yeah. Wow. So many people have actually, not so many, but many people have mentioned they've got fibromyalgia as well. Oh, sure, Karina. I'll come back to that for sure. We've got a good point from Roxana here. Absolutely makes a good point. And of course, we can't, there are multiple reasons why there are comorbidities. They may not necessarily be because of the primary arthritis condition that you have. Absolutely. But we're just trying to look through that particular lens. But Roxana made a really good point in that older women may have multiple comorbidities, and this may be due to if they had children, so from childbearing problems, absolutely. And that impacts most or all aspects of their life. And she's also mentioned that's never usually discussed, as rheumatologists have no idea about quality of life being impacted by other peripheral problems. Yeah, it's a really good point. Interesting to see the fibromyalgia, and with the fibromyalgia comes other forms of conditions as well. And then we spiral off in that direction because fibromyalgia is a very complex neurological, like nervous system, central and peripheral nervous system condition, which affects you systemically. Thank you for sharing those. I will stop sharing that point now. Now, remember, there are many other comorbidities. These were the most common ones that I saw from research. Okay, so of course we have the same as osteoarthritis, so heart disease, hypertension, depression, diabetes. Not the same in terms of, it didn't come up nearly as much as osteoarthritis. So in terms of the weight, being overweight or obese. So that didn't come up as common for inflammatory types of arthritis as it did for OA. But what we did have was that there was often comorbid with osteoarthritis. There was also kidney and liver disease, osteoporosis, and also lung disease. So we'll have a talk about why this might be the case. But in a moment, because there's one last thing I'll look at before we look at the medications, because often, not all the time, but often medication may be the driver in some of these other comorbidities. So then we have fibromyalgia, which was interesting that people did write that in there, because I didn't include that as a common comorbidity, though it certainly can be seen. So fibromyalgia is and I'm not going to do it justice because fibromyalgia needs its own 3-hour lecture, as it's so complex. Fibromyalgia is generally it's pain, widespread pain, abnormal pain, perception, processing condition. So it's about the processing of pain in our brain, including our spinal cord and also peripheral nerves as well. It causes widespread pain, extreme tiredness and fatigue. The known risk factors here can be age, though you can develop fibromyalgia at any age because of the reasons why it can occur, but often it's middle-aged. Known risk factors can be lupus or rheumatoid arthritis. So that can be the trigger to developing fibromyalgia. Sex, so it's often females that develop fibromyalgia versus males. If you've had a stressful or traumatic experience, or if you've suffered from PTSD, that can also be a known risk factor. We have injuries, musculoskeletal injuries, whereby the tissue itself has healed, yet this pain still persists and you end up with chronic pain. That chronic pain then can develop into a more widespread, severe form, being fibromyalgia. And obesity can also be a risk factor. It can co-occur with other types of arthritis like OA, systemic lupus, and ankylosing spondylitis. So fibromyalgia, as I mentioned, is widespread pain in joints and on tissues, and it can be confused with arthritis because it does cause pain in joints, muscles, and soft tissues, as I mentioned. But it's more considered a it's more considered a pain disorder, and in that respect, it's considered a neurological or nervous system condition. And they affect many aspects of daily life, including sleep and memory. People often complain about fibro fog. So just difficulty in concentrating and difficulty in short-term memory and working memory, particularly working memory. So I've had people call in and say, you know, that they're a middle-aged woman, they may be at the height of their career and they're feeling very stressed and anxious about how they're going to go forward because they can't even remember a telephone number. So I've had conversations with people calling in the 1-800 info line, talking to me about this, and they've had a form of arthritis as well. But interesting with fibromyalgia, yes, there's fatigue and tiredness. It is often accompanied by depression, anxiety, pain, again, abnormal pain processing issues, but also digestive problems, huge digestive problems as well. So irritable bowel syndrome, for example. Again, definitely pointing towards that fibromyalgia is a systemic neurological condition. Okay, so in terms of benefits of increased physical activity, and these are on the most common comorbidities for mainly osteoarthritis, but also inclusive of inflammatory arthritis. So for heart disease, and with osteoarthritis or arthritis, the benefits of physical activity. So this helps to lower blood pressure, general better physical function, so general movement, range of motion, and it can help lower low density lipoprotein cholesterol levels, which is really, really important because the LDLs are the ones that are going to block those coronary arteries, for example, or other arteries in the body. Benefits of increased physical activity for diabetes. So this can help stabilize glucose levels. So can lower blood glucose levels. There's better weight control. Again, lowered blood pressure, certainly improved mood. And for obesity, we use physical activity to control weight, reduce the risk of those other comorbidities being heart disease and diabetes, certainly can help to improve mood, and really, really important to maintain strength of muscles and strength of bones. Okay, let's have a little look at medications and common side effects and how they tie back to the comorbidities of arthritis in general. Okay, so we've got, now I couldn't include all, FYI, I could not include all medications, certainly not. Again, there's too many, but I've included the most general ones. So we've got oral and topical non-steroidal anti-inflammatories. And so these are, and I included these because there's the most widely prescribed pain medication for those people with arthritis. But they do carry a black box warning because they pose cardiovascular risks. So hypertension, heart failure, stroke, and myocardial infarctions. So, and they should be prescribed with a certain caution. You can get certain grades or levels of NSAIDs. Certainly the topical NSAID isn't as systemically acting as the oral, so probably seen a little safer than oral NSAID. So long-term use though can actually put you at danger or at risk of developing your heart disease, which is why we may see it more commonly with people with arthritis, in people with arthritis. So if you're treated with NSAIDs, you're at higher risk of developing this, whether it's osteoarthritis or an inflammatory type, and particularly, again, long-term. When it comes to duloxetine, should I say, now this medication, it's got a broad sort of use. It is a serotonin norepinephrine reuptake inhibitor. We often use this to treat depression and anxiety, and it may be used in that particular respect, but it can also be used for pain by nerve damage associated with diabetes. Also to treat fibromyalgia, because it acts in the brain. And we know that fibromyalgia is a neurological or nervous system condition. And also for chronic, so long-lasting pain that is related to muscles and bones. And so it comes with its own side effects. So again, we have general nausea, constipation, fatigue, diarrhea, and skin reactions. It'd be interesting to note whether your doctor has prescribed this, not from a mental health perspective, but if you are on a chronic pain or you have fibromyalgia, it'd be interesting to see whether you find that works for you or not. Then we have interarticular, but also general oral and injectable corticosteroids. Okay, so, oops, my apologies. Sorry. There we go. So these, sorry, apologies. Steroids, corticosteroids, glucocorticosteroids, all of those types of medications pose a risk to the development of osteoporosis and the risk of damage to soft tissue such as tendons and ligaments. So obviously in osteoporosis, that condition is the breakdown of bones faster than new bone can rebuild it. And again, this causes the bones to be brittle and break more easily. And so people with, more often than not, inflammatory types or forms of arthritis have a greater risk of developing osteoporosis because of inflammation and some of the drugs used to treat this, one of them being the corticosteroids. And while osteoporosis itself doesn't cause, it's sort of called a silent disease, isn't it? Often because it doesn't cause a lot of noticeable symptoms. But obviously bone fractures may result from it, and these obviously are quite painful and debilitating. So it's important to note that corticosteroids do pose a risk to osteoporosis, osteopenia, but also soft tissue damage like damage to tendons and ligaments. So it's very important that you are managed well from your doctor or whoever may be providing these injections. They weaken nearby tendons, therefore they're more prone to tearing. And so often the case is that the injection, if it's injectables, it's not injected directly in the same site. It might be slightly different site, but often there's time in between. So time needs to be left. Also, post cortisone injections, it's best to rest for a few days after this, and then gradually increase activity with recommended stretching and strengthening exercises. So when it comes to bone and cartilage loss, certainly research suggests cortisone injections, but also oral, long-term use of oral medications has a negative effect on cartilage, and also affects how the body uses calcium and vitamin D to build bones. So steroids, yes, can lead to bone loss, osteoporosis, and essentially or evidently broken bones. And lastly here, we have DMARDs and or biologics. So these are the big players, the big hitters. These suppress our immune system. So these are really working on the adaptive immune system and to help control inflammation. And all of them will increase your risk of infection. So this is where other conditions, maybe more short-term infections, may come into play as, I guess, a consequential comorbidity. So of course, if you've got signs of, chills and fever, a sore throat and other things like this, it's important to report directly to your doctor and ensure that you aren't unwell with a form of bacterial or virus infection. So last but not least here, my poll. Oh, never mind. I thought what we might try, which might be interesting, let's see. We've got just if you can hang on just a few more minutes, I'd like to see if we could use a function on Zoom here. It's called a whiteboard. So if I select the whiteboard and I open it here, I'd like us to share, if we can, some of the potential tips or ways we might manage these certain types of side effects from our medications. So common side effects from medications include, these are really common ones, and they may just be part of the disease process itself. For example, headaches, general fatigue as well, nausea. So I thought what might be interesting is if we could share some of these with each other on the whiteboard. So what you need to do, if you can see the whiteboard on your screen, it should just be a white page. On the side of it, you'll see a panel. All you need to do is select the T. So you click the T and you draw a box, and then you can write what you want to write. So how do you manage your side effects? So it could be from medications or condition itself. And so if I make that bigger, there we go. So can I get a thumbs up, a hands up if you go, if you guys can see that right now? Yes. If you'd like to participate, you can. I'm just using it as something a little bit different. You're more than welcome to put it into the chat box if you like, but here we can see it all on the one screen. So if you'd like to try that, selecting the little T on the left-hand side of your screen, you can select that. Oh, excellent. I've got someone writing over here. And if you need to go, that's not a problem. We're only going to be a few more minutes, but if you need to go, not a problem. I've got someone writing in here now on the whiteboard, resting. Meditation in a spa or hydro pool. That sounds amazing. Whoever wrote that, that sounds awesome. Meditation is one of those sort of blanket management tools, I think, because not only is it good for our mental health, our well-being, but I think physically also it can help feel us rejuvenated. Remember, if you're having trouble with the whiteboard, you can also use the chat box if you'd like to share tips and tricks on how you manage your condition or the effects from your medication. Relaxing with a hobby, great. So I'm looking to focus on, awesome. Distraction is a really good way to deal with getting through. Let's just say you're going through a really bad or severe pain flare. Not only physically feeling pain, but also the feeling mental well-being as well. So anxiety, depression, focusing on something like a hobby and using a tool such as distraction can really help. So you really want to get into a sense of a mindfulness while you do this activity. Hydrotherapy has really helped. Fantastic from a hip replacement. That's great. I'm just reading some comments in the chat box. Using a limited amount of methotrexate. That's good. Also, yoga and meditation, relaxation are powerful tools. I think walking and listening to music, I think that's what was mentioned. Exercise, excellent. Somebody likes to use heat. Other people might find that they actually like to use cold or ice therapy. Wonderful. Oh, interesting. Karen says that her doctor has put her on cannabis oil and has reduced the pain and able to get a good night's sleep for the first time in years. Oh, that's fantastic. Really good to hear that. If you don't get a good night's sleep, just how can you function the next day? So that's really awesome to hear that that worked for you. That's okay, Ellen. Can't access the whiteboard, not a problem. Ellen mentioned that they gave up all prescription medication. Interesting. And now I rely solely on paracetamol, only when it's necessary. I rely on medication, plasters, and liniment and heat bags, which I make myself. Okay, great. And if that's the way you're managing yours and it works for you, that's good. Laura, well, thank you very much for sharing with me your thoughts and tips on side effects that you may be experiencing. What I thought I might ask, as we've just gone over 5 minutes, is if you wouldn't mind sharing with me perhaps some other things that you may have liked to talk about or hear about or learn about. If there's anything that you'd like to write or share in the chat box, now is the time, or forever hold your peace, because what I can do for the next session is adapt the PowerPoint and include some other interesting points that you may have given me today. So is there anything else that you may have liked to have heard about or like to know about? Not a problem for those people who need to leave. We'll chat to you soon. You're welcome to come off mute as well and tell me if you like. Or if it was that great and you've got no other comments, then I certainly did my job well. Thank you, everybody. Very interesting. Thank you. Have a good day. Okay. Now, Karina, I think you had a question or two. I'm sorry. I hope I answered that. If you wanted to ask me again, you can now. Helen, if you're still on the chat, that's a really good question, whether duloxetine can be used with pacemakers. I don't know whether it has I highly doubt it has an interaction with pacemakers, but not a doctor, and please talk to your doctor about this. It can be used for pain relief. It depends on the type of pain that you have. If it's due to chronic pain changes in your brain, then yes, the research does say that it can help. So I think that it's worth investigating. If you haven't tried it, certainly have that conversation with your doctor about it. Thank you, thank you, thank you. All good, I found the info. Thanks, sorry. Okay, thanks, Karina. All right, guys, a bit more information on the reason that long-term conditions such as arthritis cause these conditions. I was shocked to see I had 5 of the conditions on the first slide. Okay, thank you very much for sharing that. I will copy that. Gastro and arthritis, sure. Excellent. Thank you for sharing that. I'm going to dump that into my, okay. All right, everybody. Well, I will call the presentation there. Thank you all for participating. Thank you all for listening. Thank you for your comments. I'm going to stay on so I'm able to copy those, but everybody else is good to go if you need to, and I will shut it down as soon as I take these comments off. So thank you so much, everybody. I hope you have a good day, rest of the day, rest of the week, and we'll see you all again soon. Bye-bye. Hormones and arthritis. That's a good one. Thank you. Thank you. All righty, I'm going to do that.